occupational English test has 3 parts, and in each part you hear a number of different extracts. At the beginning of the test, you will hear a beep sound. You have time to read the questions before you hear the extracts. You will hear each extract only once. You have to complete your answers as you listen. At the end of each test, you will be given 2 minutes to check your answers. Part A. In this part of the test, you will hear 2 different extracts. In each extract, a health professional is talking to his patient. For questions 1 to 24, complete the notes within. For questions 1 to 24, complete the notes with the information you hear. Now, look at the notes for Extract 1. Extract 1, questions 1 to 12. You hear a doctor talking to a patient called Paulina. For questions 1 to 12, complete the following notes with a word or short phrase. You have 30 seconds to look at the notes.
Hello, good morning, doctor.
Good morning. Tell me, what's your problem?
Well, I have a history of first-degree atrioventricular block and had a pacemaker placement. I feel this problem of decreased eye vision. Last time the problem lasted for about 5 minutes. That occurred 4 weeks ago when I was driving the car.
Then how did you manage to drive?
Well, I was able to pull the car over to the side of the road without much trouble. During that time, I felt nauseated and lightheaded. When I approached the clinic at that time and received a CT scan, carotid Dopplers, echocardiogram, and neurological evaluation, all of which were unremarkable. I couldn't have an MRI due to the pacemaker placement.
Okay. Did that occur again?
No, doctor.
Any lesions or change in vision, headaches, change in gait, or other neurological issues?
No, doctor.
Do you have any back pain, bowel or bladder incontinence, or frank lower extremity weakness?
No, doctor.
What's your age?
57, doctor.
Do you drink or smoke?
I don't smoke, but I drink alcohol, only on some special occasions.
Any past illness or surgeries?
I had pacemaker placement for atrioventricular block, and I had bilateral knee replacement 3 years ago and have some pain in my knees.
What medications are you taking?
I have recently started on Plavix, suggested by primary care doctor. Other than that, baby aspirin, 81 milligrams per day, Proscar, 5 milligrams, GD, and Synthroid, 0.2 milligrams daily.
Are you allergic to any medication?
No, doctor.
Well, your physical examination shows your blood pressure at 134/80, your heart rate 60, respiratory rate 16, and weight is 244 pounds. Cranial nerves 2 through 12 are intact, and you have normal bulk and tone throughout. There's no cogwheeling. There is some minimal weakness at the R4 plus or 5, and possibly trace weakness at the quadriceps -5 or 5. You have decreased sensation to vibration and proprioception and vibration. There is no dysmetria or tremor noted. His Romberg is negative. You have developed transient ischemic attack. The character of his brief episode of visual loss is concerning for compromise of the posterior circulation. Differential diagnosis include hyperprofusion, stenosis, and dissection. You have lumbar stenosis. The symptoms are very mild and consist mainly of some mild proximal upper extremity weakness and very mild gait instability. You have to get a CT angiogram to evaluate the integrity of the cerebrovascular system. Extract 2, questions 13 to 24. You hear a physician talking to a patient called Mrs. Emmeline Pethick. For questions 13 to 24, complete the following notes with a word or short phrase. You now have 30 seconds to look at the notes.
Hello, good morning, doctor.
Good morning. Tell me what's your problem.
Well, I have a Codman-Haycom shunt set at 90 millimeters H2O. Recently, I'm getting acute onset of headaches, and it's worsening day by day. I am unable to sleep. The pain is constant and is worse with coughing, straining, and sneezing, as well as standing up.
What's your age?
40, doctor.
Did you take any medicines then?
Yeah, I've tried taking Imitrex as well as Motrin 800 milligrams twice a day, but it has not provided much relief. Although the pain is generalized, it is quite intense in the frontal region of head. I get a feeling of ringing in the ears. I have been experiencing intermittent blurry vision and dimming lights as well.
Do you drink or smoke?
No, doctor.
Well, I've reviewed your diagnosis reports. Your physical exam reports show blood pressure at 153 over 86, pulse at 63, and respiratory rate 16. Cranial nerves intact for extraocular movements. The shut site is clean, dry, and intact. You have a small 3 millimeter to 4 millimeter round scab that was noted farther down from her shunt reservoir. It looks like there's a little bit of dry blood there. The worsening headaches are secondary to shunt adjustment back after an MRI. You have pseudotumor cerebri without papilledema and migraine headaches. Well, your shunt back programmed to 90 millimeter H2O last time was after confirmation of an X-ray. However, it seems the picture of the X-ray last time was not most desirable. Therefore, I'm planning the shunt back to 90 millimeter H2O again tomorrow. So, you have to have another skull X-ray to confirm the shunt back program to 90 millimeter H2O.
That is the end of Part A. Now look at Part B. Part B, in this part of the test, you will hear 6 different extracts. In each extract, you will hear people talking in a different healthcare environment. For questions from 25 to 30, choose the answer A, B, or C, which fits best according to what you hear. You will have time to read each question before you listen to the audio. Complete the answers as you listen to the audio. Now look at question number 25. Question 25, you hear 2 doctors having a discussion about chemotherapy for bladder cancer. Now read the question.
Doctor, could chemotherapy inside the bladder reduce recurrence of cancer?
According to a recent study, patients who had the chemotherapy drug gemcitabine placed inside their bladder following the resection of the tumor had fewer recurrences. Out of more than 400 subjects, 384 completed the trials and were included in the study, which randomized them to receive the chemotherapy drug called gemcitabine. To treat the bladder cancer, they implanted it into the bladder and let it settle there for an hour, and the other group with saline without gemcitabine in it. They kept the patients under observance for every 3 months for 2 years, thereafter every 6 months for another couple of years. What they observed was the recurrence were 34% less. The purpose of this study was to prevent bladder cancer from invading the muscle wall of the organ. Moreover, this is a very simple method without any significant side effects. Question 27. You hear two doctors discussing occupational therapy for improving visual function. Now read the question.
Doctor, can visual function be improved through occupational therapy?
Well, findings proved that occupational therapy for patients with poor vision performed at their home and directed particularly toward helping them with both meaningful and challenging tasks, helped avoiding depression that actually improved the visual function as well. It was observed that those with milder visual impairment actually performed much better on these questionnaires after the occupational therapy group, whereas those who were in the supportive therapy attention control group could not improve their visual function measures. Therefore, the occupational therapy role not only improved in some of these depressive symptoms, but also in this specific subset of patients with mild impairment did improve their visual function as well. The comprehensive approach to rehabilitation, including in-home occupational therapy for those with visual impairment, is the key to improving visual function. Question 28. You hear two doctors talking about why primary doctors should not perform eye screening. Now read the question.
Doctor, why shouldn't the primary care doctor perform eye screening of the patients?
Well, according to the recent recommendations of the United States Preventive Service Task Force, the primary care doctor shouldn't include a vision screening to the list of primary tests for his patient in his office. To know why vision screenings may not trace out the precise vision impairment, we need to look at the factors that can restrict the effectiveness of the results. Many vision screenings are performed only for distance visual acuity, and it does not give any indication of how well the eyes work together or focus up close. It also does not give any detail about the eye health. Although certain screenings may include a plus lens test for farsightedness and eye coordination tests, even these screenings will often fail to detect many vision defectiveness. Often, a vision screening is conducted by primary doctors or administrative personnel who have little training, who haven't the complete knowledge to assess screening results, even if the screenings are performed in pediatrician's or primary care physician's office. The scope of vision screening may be restricted by the type of lab equipment. Question 29. You hear two doctors discussing dysphagia after the use of breathing tubes in ICU patients. Now read the question.
Hello, doctor. Is trouble with swallowing common following use of breathing tube?
Breathing tubes are meant to save lives, and they are often used for critically ill patients as well as during various surgeries. However, using breathing tubes has a side effect of difficulty in swallowing called dysphagia. In the ICU, patients had breathing tubes down their throat, typically more than 48 hours, will have a minor difficulty of swallowing and some voice problem as the tube is pulled. If it becomes worse, it can last years afterwards. According to the findings, most patients in this 5-year study recovered from their dysphagia within 6 months. However, there are also cases of the condition lasting up to 5 years. The good news is that even in patients with the prolonged periods of dysphagia, ultimately they did recover some function. Question 30. You hear two doctors talking about risk factors for kidney donors. Now read the question.
Doctor, how risky is donating one of our kidneys?
Well, there is an online risk tool to calculate the long-term risk of end-stage renal disease in people who are willing to offer kidney donation. This tool includes many characteristics in contrary to single characteristics used earlier. This multitude of characteristics help develop a comprehensive picture of risk in donating a kidney. This tool incorporates 10 different characteristics that are specific to the person willing to be a donor and provides an estimation of the absolute risk of end-stage renal disease over a certain period of time, say 15 years.
That is the end of Part B. Now look at Part C. Part C. In this part of the test, you'll hear two different extracts. In each extract, you'll hear health professionals talking about specific aspects of their work. For questions 31 to 42, choose the answer A, B, or C, which fits best according to what you hear. Complete the answers as you listen to the audio. Now look at Extract 1. Extract 1. Questions 31 to 36. You hear the doctor briefing his staff about guidelines for the early detection of cancer. You have 90 seconds to read questions 31 to 36. Guidelines for the early detection of cancer. I am going to explain to you the guidelines for screening different types of cancers. These screening tests are suggested to detect cancer before the patient develops any symptoms. Colon and rectal cancer and polyps. Starting regular screening at the age of 45 is suggested for people at average risk of colorectal cancer. The screening can be performed either with a sensitive test that examines for cancer signs in the stool of the person or with an exam to look at the colon and rectum. This can be done either with a sensitive test that looks for signs of cancer in a person's stool or with an exam that looks at the colon and rectum. If the person is maintaining a good health, he should continue with regular screening through to the age of 75. For people aged 76 to 85, they should confirm with the physician whether continuing with the screening is right or not. People above 85 should no longer get colorectal cancer screenings. If the person wishes to be screened with a test other than a colonoscopy, any abnormal result should be followed up with a colonoscopy. Cervical cancer. Cervical cancer screening should begin at age 21. However, women below 21 years should not be screened. Women between 21 to 29 should have a Pap screening done once in every 3 years. However, HPV screening should not be performed for this age group unless it is required after an abnormal Pap test result. Women between 30 to 65 should have a Pap test in addition to HPV test termed as co-testing done every 5 years. This is the most suggested approach. However, having a Pap test alone is also okay for this age group. Women above 65 who have had regular cervical cancer screening for the past 10 years with normal results should not be tested for cervical cancer. Once screening is discontinued, it should not be started again. Women with a history of severe cervical precancer should continue screening for at least 20 years after that diagnosis, even if testing goes past age 65. The women whose uterus and cervix have been removed, total hysterectomy, for reasons not related to cervical cancer and without any cervical cancer history or severe precancer should not be screened. Women vaccinated against HPV should still follow the screening recommendations for their age groups. Women with a history of HIV infection, organ transplant, DES exposure, etc. may require a different screening schedule for cervical cancer. Breast cancer. Women from 40 to 44 should have the choice to start annual breast cancer screening with mammograms. Women from 45 to 54 should get yearly mammograms. Women above 55 may get mammograms once in every 2 years. Screening should continue as long as a woman is in good health and is expected to live more than 10 years. Women should be well informed with the known benefits, potential harms, and limitations linked to breast cancer screening. Certain women with a genetic tendency, family history, or certain other factors should get screened with MRIs along with mammograms. Endometrial cancer. I would recommend that during menopause, every woman should be informed about the risks and symptoms of endometrial cancer. Certain women with a disease history may need to opt for a yearly endometrial biopsy. Lung cancer. I would recommend yearly lung cancer screening with a low-dose CT scan for certain people prone to lung cancer who meet the following criteria: aged between 55 to 74 years and maintaining good health, and stopped smoking in the past 15 years, and having a minimum of 30 packs per year smoking history. Prostate cancer. I would recommend that men make an informed decision after consulting with a physician whether to be screened for prostate cancer. Research has not yet proven that the benefits of screening outweigh the harms of testing and treatment. Therefore, I believe that men should not be screened without understanding about the risk factors and benefits of screening and treatment. Starting from the age of 50, men should consult a physician about the risk factors and benefits of screening so that they can decide if screening is right for them or not. If they are African American or have a father or brother who had prostate cancer before the age of 65, one should consult a physician right from the age of 45. If one decides to be screened, he should get a prostate-specific antigen blood test with or without a rectal exam. How often he will be tested will depend on his prostate-specific antigen level. Extract 2. Questions 37 to 42. You hear the doctor giving a lecture on the effect of disrupting gut-brain communication. You have 90 seconds to read questions 37 to 42. According to research findings, disrupting gut-brain communication may affect memory and learning abilities. The link between memory and food is a fundamental human experience that we all can relate to. However, the findings have unveiled an intriguing explanation behind this phenomenon, illustrating how strongly the second brain in our gut communicates with our brain. A massive mesh of neurons termed as second brain lies inside our gastrointestinal tract. While this neuronal control system primarily functions independently to manage our digestive system, the study reveals that this neuronal control system communicates with the brain directly through a long nerve called the vagus nerve. The vagus nerve mediates a great deal of metabolic communication between the gut and the brain. For instance, the study revealed how feeding behavior initiated by hippocampus activity is directly activated by vagal nerve stimulation, mediated by signals from the gastrointestinal tract. It appears obvious that signals from the gut would be communicating with the brain in this way, allowing us to know when we should stop eating. But what if these gut to hippocampus communications covered satiety clues or more than simple hunger? Could they also impact cognitive and other memory processes regulated by the hippocampus? A study conducted on this topic that utilized a novel rodent model that terminates about 80% of gut to hippocampus communicators while still retaining fundamental brain to gut motor signaling. The study revealed that when this gut-brain pathway was detached, the rats displayed impaired episodic and spatial working memory. That means the rats could not effectively generate and access spatial memories provoked by the gastrointestinal system. With this disrupted pathway, a fascinating link between our gut and memory is hypothesized. When rats locate and eat a meal, the vagus nerve is activated and this global positioning system is engaged. Therefore, it would be advantageous for an animal to remember their external environment to locate the food again. The artificial electrical stimulation of the vagus nerve can increase memory function. However, this is the first study to find an endogenous connection from the gut through to the hippocampus that mediates this cognitive pathway. Interestingly, this study revealed that the specific vagal nerve disruption studied here did not affect social learning, body weight, or anxiety. The study concluded by raising a concern over the lack of research in this subject. It is recommended that common bariatric surgeries, such as a gastric bypass, have been found to reduce the effectiveness of vagal nerve signaling to the hippocampus. Moreover, a recently approved FDA obesity treatment called V-block therapy has been effective in weight loss by electrically disrupting the vagus nerve. That is the end of Part C. You now have 2 minutes to check your answers. That is the end of this listening test.